morning, ladies and gentlemen. The theme of my PhD program is New Insights into Viral Infection-Related Acute Pancreatitis. My name is Gefu, and I am a PhD student and biologist from CTM. My vision is to improve the prognosis of acute pancreatitis patients by exploring the effects of virus infection on the GI system. Now, I have two specific goals to achieve my mission. The first one is about concomitant virus infection in acute pancreatitis, and second one, we would like to investigate the prevalence and role of acute pancreatitis in COVID-19. Let's start with the first one. Concomitant virus infection increases mortality and worsens outcome of acute pancreatitis. It is a systematic review and meta-analysis. Acute pancreatitis, or AP, could be mild, but 20% of the patients can develop to severe with 40% mortality in those severe forms. And acute pancreatitis is also associated with several kinds of virus infections, such as mumps, Coxsackie virus. And in recent years, acute pancreatitis is reported as a complication of COVID-19. Besides, virus infection could be the direct etiology of acute pancreatitis. We believe that virus infection might be the potential trigger for acute pancreatitis. So we aim to investigate the effects of concomitant virus infection in acute pancreatitis. We would like to ask, what are the effects of virus infections on the clinical outcomes in AP? We included the AP patient, and the exposure would be a concomitant virus infection. The primary outcome is mortality and severity of AP. The secondary outcome is complications, and we assume that concomitant virus infections such as HBV are associated with a worse overall outcome in AP. We conducted a systematic search based on English databases and Chinese databases, and at the end of the selection, we got finally 29 cohort study and more than 500 cases reports. Now let me introduce the most interesting results from our project. Table 1 shows included virus which are related to acute pancreatitis and the size of the population. And Table 2 shows the prevalence of the main outcomes in the infected and control population. For example, in-hospital mortality is 18% with the SARS-CoV-2 infection compared to 6% in control group. Let's go further. Figure 1 is the forest plot of the in-hospital mortality in AP patient with several SARS-CoV-2 infection and without infection. We choose odds ratio as our effect size, and the odds ratio 3.15 shows the in-hospital mortality has more than 3 times higher odds in affected group compared with control group. And the confidence interval and I-square shows this result is statistically significant and has a low heterogeneity. We also investigate the severity of AP, and we could say at least moderate AP, which means moderate and severe AP is more common with the SARS-CoV-2 infection, and the odds ratio shows the risk is 2.72 times higher in infected group. Necrosis as a complication of acute pancreatitis is more common with SARS-CoV-2 infection as well, and the odds ratio shows the risk is 1.48 times higher. Another subgroup, we investigate the HIV subgroup. The odds ratio 1.13 and 1.21 shows that there is no significant difference between HIV-infected AP patient and the regular AP patient in hospital mortality and the risk of sepsis. So we can conclude that SARS-CoV-2 infection worsens the prognosis of acute pancreatitis. It increases mortality and get more severe outcome in AP patients, and it increases prevalence of the local complications such as necrosis. And by the way, we also investigate the overall outcome overall organ failure as a complication, but the results is not significant, but still can be clinically relevant. However, the HIV infection, it is not expected to have a higher risk for complications and worse overall outcome. To summarize the implications, in practice, it is important to consider viral infection in the assessment and management of AP. Patients need a closer monitoring for local and systematic complications and timely intervention or treatment. But in research, in cohort studies, the possible viral infection should be more possible viral infection should be investigated, and more accurate registration for complications and outcomes in case reports and cohorts is needed. Our meta-analysis is the first comprehensive investigation on viral infection and AP. We included a high number of the articles and types of virals, and lots of complications are investigated, but our study only includes cohort study and case reports, and the report of complication and outcome is not completed in case reports. We just submitted our article in this month to American Journal of Gastroenterology, and we are waiting for response. Regarding the second project, we would like to investigate the prevalence and the role of acute pancreatitis in COVID-19. It would be a respiratory analysis. COVID-19, as we know, is a deeply affected and worldwide pandemic. The periodical emergence of human coronavirus, which happened in 2003 and 2019, suggests that we might face a similar situation in the future. And in these figures, we could see both pancreatitis-inducing factors and the SARS-CoV-2 infection could elevate lipase activity and release unsaturated fatty acids. This kind of lipotoxicity could induce cytokine storm and finally result in severe disease both in lung and pancreas. And also, acute pancreatitis may occur during the COVID-19, and the prevalence of the AP and the association between AP and COVID-19 still remain question. We would like to investigate it. The clinical question would be, does the presence of AP change the prognosis and the management of COVID-19 patients? We included COVID-19 patients, and the exposure is the presence of AP. The outcome would be mortality severity of COVID-19, complications, and mechanical ventilation. We assume that presence of AP makes worse prognosis of COVID-19 patients and need a more cautious management. We would like to use data from coronavirus registry, which including more than 1,700 cases from 5 centuries, it including a pediatric and adult population, and we would like to investigate the disease with the following 5 aspects. Now, the progress, we just submit the preliminary data retrieval plan and receive the data table. Now we are polishing the data and try to ask further details about the patients and to try to make a statistical analysis plan. So let me summarize projects. The first project we submitted it in June, and we plan to submit the second project in October. For additional activities, I have attended the Nobel Prize Lawrence lecture with Bruce A. Butler in Stuttgart, and I'm great honored to receive the Best Poster Award from Semmelweis Symposium 2023, and have a chance to shake hands with Randy Schickman, another Nobel Lawrence, and we are going to attend the EPC conference next week. I'm so glad to work with work with our standing colleague and supervisors for past 2 years. Thank you for your attention, and I would like to end my presentation with a quote from Albert Einstein: "In school and life, the most important driving force of work is the pleasure in work, the pleasure of working as a result, and the recognition of the social value of this result." Thank you.
Can we go to your first conclusion?
Sure.
So I just wonder, does it matter at what stage COVID infection affects the prognosis of acute pancreatitis? Because there is a kind of acute phase and there are post-COVID kind of things. Same applies for HIV, because HIV, I mean, that's one thing if somebody gets infected in HIV. The other thing is if the AIDS symptoms are coming up, and then there are different stages of those. So maybe actually if you put everything together, I mean, it may just overshadow some of the changes. So, I mean, just one by one in the COVID, that based on the literature, I mean, are there differences between different severity of COVID, different kind of timing of the COVID infection on the acute pancreatitis?
Yes, thank you for the question. For our, in our results, I think we didn't make a subgroup for the severity of COVID-19, but but I think it might influence overall outcome of the acute pancreatitis. We can still make efforts on it.
Same thing about HIV again, because that's one thing that somebody gets HIV. Another thing is that the real disease is coming, and then whether that's a kind of, in some people that goes to an end stage and then to death. So did you have data on those?
Yes, maybe we could see the sepsis. We could see the results from from the figure 4. We could see maybe the MS CAPEL 1995. The odds ratio is much higher compared with others, because this results. Because this article is from the South Africa, and it mentioned 40% of the patients is not well treated by the antiretroviral therapy. So I think it definitely results influence the results. So the patients have more severe symptoms of the HIV. So.
First of all, let me congratulate you. I think we all agree that your progress has been the most visible in our group, so really congrats. Since you joined us, I feel like your presentation technique has evolved a lot, congratulations. I have a small question. So if we have an acute pancreatitis patient, should we screen them for any viral infection, or what do you think?
Yes, definitely, but it depends on a lot of elements. For example, the cost, the possibility for the screening. But I think HIV and the SARS-CoV-2 infection definitely should be screened when a patient hospitalized in hospital. But for other virus, I think there are. We also collect lots of cases report, and there are some interesting cases. We can't do the meta-analysis on it, but we can still make some discussion. For example, the old world hantavirus. It's not very common in America, but it most happen in Asia and Europe. The patients hospitalized with acute pancreatitis and concomitant hantavirus infection, their occupation most of their occupation are farmers. I think that's because the hoster of hantavirus is rodents, and the farmer has more chance to contact with these kind of animals and get more chance to get infected. So maybe if we get those kind of patients who are farmers and male hospitalized with acute pancreatitis, we should screen the old world hantavirus, I think.
Congratulations for a nice presentation. I would like to actually ask about exactly the HIV population. So as far as I know, many patients who are very well treated with HIV are basically totally asymptomatic, etc. And actually the important thing in HIV population is CD4 count. So do you have any information how the patients with low CD4 count actually behave compared to either patients with no HIV or those with good CD4 count?
Yes, there are lots of. There are some limitations with our studies because we cannot eliminate the confounders because study type, the CD4 level is not reported very well in those articles, but also I think age is another confounder for our studies. So it's really hard to find out a conclusion about it, but we can do some case-controlled studies to eliminate confounders. Thank you.
You showed us that COVID infection actually worsens the outcome of acute pancreatitis. Is it right? Did I understand it correctly? In that case, did you have any data? Did you do any comparison based on etiologies of acute pancreatitis, whether it is differed in COVID-positive patients or compared to COVID-negative patients? Do you have an increased number of patients with so-called unknown etiology, which might give us some hint that the COVID infection itself is the provoking factor of acute pancreatitis?
Yes, thank you very much. We are also very interested about the etiology factors. Yes, we tried to collect the etiology of all the patients, but the studies only report the etiology as their basic characteristics, and we can't make a subgroup for the etiologies. But yeah, I think it could be the future direction to investigate if the etiology could be the risk factors in this topic, and also there is another very interesting etiology about the liver transplantation. So we collected some cases about the liver transplantation patients after the surgery. They got a chance to get infected by cytomegalovirus, and this infection could be the potential trigger to induce acute pancreatitis. And I'm not an expert. I don't know if there are some potential operative to avoid the patients to get the infection in the liver transplantation surgery. That's it.
Thank you very much for the nice presentation. I do understand that you haven't started the statistical analysis of the second project yet. Yeah. Still, I'm asking whether you have anything in mind. What kind of statistical methods do you anticipate to use in order to answer your research questions?
I'm sorry, we haven't reached that step, but we are just checking the patients. We are checking the diagnosis information about the patients, and we need to ask further information about the patients. So.
I see. Okay, okay. And then another question. So you used you calculated the odds ratio. My question is, do you know what the difference is between odds ratio and risk ratio, and when to use which?
Yeah, sure. Thank you for the question. And the risk ratio is ratio of the possible. Probability of two groups, and the odds ratio is the ratio of odds to compared between two groups. So we have some studies are case control studies, and it's more suitable for the odds ratio, and also there are some rare events, and also odds ratio is better for it, so thank you.
First of all, congrats for the nice presentation. I unfortunately missed the first part, so maybe it was mentioned. But I was just wondering whether this effect of COVID infection on the severity of acute pancreatitis can depend also on actually the virus. I mean, in which mutant the virus causes this infection, because I assume these studies are from the first year, so 2020, 2021, and in that case, the infection in most cases was more severe than nowadays. So do you think that the new mutants have the same detrimental effect on acute pancreatitis?
Thank you for great questions. We also make efforts on it, but it can depend on, maybe we can find some clues, depend on the publication years, but I think most of the articles have a long period, so the patients maybe contain, I think, all kinds of mutations, so I can hardly tell what's the difference between each kind of mutation.
Okay, thank you.
I'm sorry.
How about the new study? Do you know that in this study, that you will use your own data or our own data? I would say that. Will you have this information, which type of COVID? I mean, in the new study, in your clinical study, that you will have a kind of, you have multiple questions. One of the questions could be that if different types of COVID viruses, so SARS-2 viruses, have actually different kind of, give different kind of risk for acute pancreatitis. But for that you need the detection of this. So do we have those?
I'm sorry, I can't.
Can we go to your second plan?
Yeah.
Okay, so you will collect samples from 5 centers. You already have this, I assume, but you didn't start the analysis.
Yeah.
Do you have the data on the type of COVID virus mutation, SARS-2 mutation?
I don't think so. Yeah.
Because that would be a great step forward, anyway. If not, I mean, this is already available data. And then, which centers are these 5 centers? Are these Hungarian centers or international?
Yes, I think it's from Hungary.
And what are the biomarkers? Because you already, I mean, I just saw that the genetic background is written there, so actually this would be the genetic background that I asked about. But what are the biomarkers that you have available from this study? Do you know, or this is just a starting phase?
Yeah, it's just start phase, and I haven't comprehensively checked it.
Okay,
Yeah.
very good.